All right, welcome everyone to a webcast on alternative access approaches and techniques for TAVR. We've got an amazing panel today. I'm Jamie McCabe from University of Washington in Seattle, Washington. We've got Dr. DeBacker, who's from Copenhagen.
Yes, correct.
Dr. Yadev from Atlanta at Piedmont, and Dr. Devareddy, also from Atlanta at Emory. All right, so this program is sponsored by an educational grant from Shockwave Medical, and we'd like to thank them for their support, and it's provided by the North American Center for Continuing Medical Education. There are a series of learning objectives today that we're going to review. One is to understand the challenges associated with calcific iliac arteries, particularly when it comes to large bore access. Another is to understand the need for non-transfemoral access around TAVR or TAVI, and identify various alternative access strategies and perhaps an algorithm to take advantage of that. And the last is to identify approaches for incorporating intravascular lithotripsy in TAVR or large bore access cases. We're going to kick it off here with a little bit of data and some conceptual framework to think about this. Then we're going to transition to our amazing clinical colleagues to describe some cases and help us understand and appreciate where lithotripsy may come into play. So, first off, it's important to recognize, particularly around TAVR or TAVI, that there have been a series of secular changes. And in particular, these have come around the development of new technologies. So where SAPIEN XT required about 20% non-femoral access, SAPIEN 3 is now down to about 5 to 6% non-TF access throughout the United States. When one does turn away from transfemoral access in TAVI these days, what we're seeing is that most of that growth or most of the non-femoral access is non-thoracic, meaning it is not surgical access from the LV apex or the aorta, but rather using conduit vessels throughout the body, whether that's the axillary or the carotid or transcaval, etc. That's really where we're seeing the growth among this diminishing population of non-femoral access cases. So, need for non-femoral access is decreasing, but when non-femoral access is being used for TAVR, it's still more often utilizing the vasculature. And I want to draw your attention to this particular paper, which I found really interesting. So this is a procedural volume and outcome relationship for transcatheter aortic valve replacement published in the New England Journal. We're going to veer from the primary message of the paper to look at some of the context of what it did show. And so first off, within the United States, almost 550 hospitals, we're looking at a median per hospital volume of TAVRs of 54 per year. Right? 1/4 of United States TAVR hospitals do less than 36 cases per year. And when you take it per operator, you're at basically half of that. So the average or the median United States TAVR operator does 27 cases per year, and 1/4 of them do less than 17 cases per year, or only a little bit more than 1 per month. Now, if you overlay on top of that 6% non-femoral access rate, you end up with a per hospital median volume of non-femoral cases of 3, and a per operator non-femoral volume case load of 1.5 non-femoral cases per operator per year. It's a really low number. And looking at secondary data sources, such as this paper published by Tom Dale et al. In JACC Interventions, of which I was a part, when we looked at transaxillary cases, most of which were surgical, by the way, the median number of cases per center in aggregate was 2. That's not per year, that's total. And in fact, almost 80% of all centers had performed less than 5. So once we start talking about non-femoral access cases, we are talking about relatively infrequent case volumes per center, and that has significant implications. So the need for femoral access is decreasing. When we are doing non-femoral access, you are still utilizing the vasculature primarily. But the median per center and per operator experience for TAVR from a non-femoral approach is really small. And when you look specifically at the volume outcome relationships, the strongest volume outcome relationship is not in femoral TAVR, it's in non-femoral TAVR. And that's going back to that same New England Journal paper. So now you've got something that we're doing infrequently, but it has the highest relationship between volume and outcomes. Particularly, this is with mortality. And this is just another sort of representation of that, showing that, again, when you're looking at femoral access, the relationship between the lowest quartile and the highest quartile volume, not that dissimilar, whereas in the non-femoral access cases, quartile 1 and quartile 2 significantly increased adjusted odds ratio for mortality. So again, just further corroborating this message. Non-femoral access needs are decreasing. When we're doing it, we're not primarily using an interthoracic conduit. The median per center and per operator experience is small, and the volume outcome relationship in TAVR is strongest when we're doing non-femoral access cases. And in fact, if you dig into that data a little bit, what you're seeing is that what drives that volume outcome relationship is primarily vascular complications and bleeding, less so acute kidney injury, stroke, etc. So really kind of drives this message home that non-femoral access is itself a little bit more difficult, has a stronger relationship with mortality. And so on that basis, I think you could say, well, if you're an average volume center and you're going to do perhaps less than 10 alternative access cases per year, maybe it's worthwhile to focus a little bit more on how to incorporate a facilitated transfemoral access program into your hospital center, where the schematics, the process are all very similar to your standard transfemoral, where your nurses and techs know just kind of how things are going to move along because they're fairly standard. Now, there will be times when that's not possible, and doing facilitated transfemoral and doing alternative access are not mutually exclusive. But I think there is a strong evidence base there to say, listen, when we need to go with a suboptimal iliofemoral vessel, can we work with that in a way that we can avoid taking on perhaps higher risk non-femoral access? And I have one quick registry slide to show you here. So these are data collated by Dr. Deveretti, who's on our WebEx and can speak more to it. But I think the point here is that in this multi-center registry of 42 patients, what you're seeing is all of them had intravascular lithotripsy to facilitate vascular access in inhospitable vessels. The valve delivery success was 100%. The vascular complication rates were very low. The access site closure method was reproducibly suture or device mediated like you would normally do, really suggesting that it is a viable access, a viable strategy in appropriately selected patients. And I want to give you one quick example of that. This is a case that we've done just to sort of speak to facilitated femoral access. You've got vessels that are certainly not terribly bad, but do have some 4 millimeter segments and 270 degrees of calcification. Quick intravascular lithotripsy facilitates sheath delivery without any trouble. You can see it there. It took almost as long as it took to show it. It was very quick, and that's sort of what we're aiming for with these cases. And that was then per-close closure without any trouble whatsoever. Just by way of conclusion, let me just reiterate, transfemoral TAVR is generally safer. I think we can all agree to that. Opportunities for non-femoral access are low, and they seem to be diminishing as the technology gets better and the sheath sizes decrease. Volume appears to matter, particularly in non-femoral access. So if you're not going to do more than a handful of alternative access cases per year, I think you should think very carefully about whether or not a facilitated femoral access strategy might be right for your hospital center. And there is evidence that exists now and a growing body of literature that will be available soon that intravascular lithotripsy can demonstrate the ability to facilitate femoral access in a safe and reproducible way. So with that, I'd like to hand it over to Dr. De Backer to give us a little deep dive into other alternative access strategies and how they may be incorporated into our TAVR programs.
So thank you for giving the words. I will first start also to elaborate a little bit more and show a bit of our own work in Copenhagen on the intravascular lithotripsy or shockwave-assisted transfemoral TAVR. So first, a very short, small introduction. Which center are we? We are a center in Denmark, Copenhagen, the capital. And as you see, this is the evolution of our volume. So we started in 2008. Currently, now in 2019, we did close to 400 TAVR cases. We are with 3 operators, so we can say we're a fairly large center. Interestingly, on these data, you can see that historically we've been always doing the majority of our cases by transfemoral approach, and that's not always been like that in many other centers. As we started with mainly the Medtronic core valve system, it was more obvious to try to look for transvascular access, whereas especially in the early days of the Sapien Edwards valve, many centers were also using transthoracic approaches. But as you see now, these last data I show you here in this graph are 2017. 7% of them were done by alternative access, 93% by transfemoral access with just local anesthesia, so no use of general anesthesia here. So last year in 2019, we did our entire TAVR program of nearly 400 cases, fully percutaneous, so using the transfemoral approach, also the shockwave or intravascular lithotripsy assisted transfemoral approach for 2 to 3% of cases. And then also another transvascular access approach, the Transaxillary approach, which we do fully percutaneous. And then for the last 1 to 2% of cases, we use the Transcaval approach. And these approaches will also be shown later in this program. So of course, a big benefit of going fully percutaneous for us is that we can stay and trim these hospitalizations lengths to an absolute minimum, which is critical for us as we are limited in bed spaces in our hospital. So as you can see in 2019, 80%, 4 in 5 patients of our TAVR patients were discharged within 48 hours after TAVR. So this is also a very nice evolution. So a small word about intravascular lithotripsy. Well, this is a principle based, based on the principle of calcium disruption by sonic pressure waves. And this was, of course, first used in urology, where calcium stones were fractured by this technology. But this has now also been introduced as a new methodology for calcified plaque modification, or you can say cracking the calcified plaque in coronary, but also peripheral arteries. So what is our experience in Copenhagen? Over the past 23 or 24 months, we have used this technology in 25 patients. So 8 patients we have used it in that would have also been treated by transfemoral approach earlier, but now with the additional use of intravascular lithotripsy, as we have it available, and we think we could diminish the risk of complications. And if we talk about complications, when pushing the borders in transfemoral approach, we're talking about the risk for vascular rupture or the risk for nasty spiral dissections or creating dissections which can evolve into thrombosis. We also used it in 17 other patients that we would have earlier refused for transfemoral approach and which we would have scheduled for alternative access. So what our typical approach is, we use the Shockwave 7mm, the largest balloon. And we always in Copenhagen have let this follow by an additional use of a non-compliant balloon, for example, a ZMAT balloon from 6, 7, or 8 millimeters. So this is one example. This is a case where you have on both iliofemorals 100% circumferential calcified plaque with an intraluminal luminal diameter of less than 6 millimeters. So in this case, 5 millimeter on the right hand side of the patient, on the left-hand side of the patient, 4.5 millimeter. So we still dare to treat patients now by transfemoral approach with the additional use of intravascular lithotripsy, even if we have 100% circumferential calcified lesions with only up to 4.5 millimeters. So as said, we use a 7 millimeter shockwave balloon. What I personally always like is to have a safety wire during the entire procedure coming from the contralateral side, as you can see on the left-hand panel on this slide. And then this can be followed by a ZMAT balloon. I think in this case I used an 8 millimeter ZMAT balloon. My experience is that the shockwave balloon is great in fracturing these calcified plaques, but it's a rather soft balloon. It's a compliant balloon. So in order to really dilate up the vessel and make enough space to smoothly introduce your larger introducer sheet, I prefer to let it follow by this ballooning with a non-compliant balloon. So this case was and perfectly. Also, the valve was a nice insertion, and there was a successful vascular closure with ProGlides. Another case where we typically use this is, even though there is not 100% circumferential calcification, for example, this case, there is 70 to 75% of the circumferent calcification on both sides of the iliofemoral vasculature. And then we even accept cases where we have minimum diameters of up to as small as 3.5 millimeters. So these are cases which we wouldn't have accepted 5 years ago for transfemoral approach, but now with the availability of shockwave, we tend to accept these cases now for transfemoral approach. So also here on the left-hand side, you see the shockwave balloon, successful TAVR insertion, and then a final closure, successful closure with a MANTA vascular closure device. So in summary, intravascular lithotripsy assisted transfemoral TAVR is considered in Copenhagen in cases when there is 100% circumferential calcified lesions with a minimum diameter of up to 4.5 millimeter and even up to 3.5 millimeter if it's not 100%, but up to 70 to 75 calcified circumference calcification. If it's less than 70 to 50% calcified of the circumference, then I don't think shockwave makes doesn't make any sense to use it, as this is typically best used in really calcified lesions. And as said before, the shockwave balloon is always followed by us by a non-compliant balloon. Sorry, I go back. So in 2019, we treated, as said, 100% of our TAVR patients by percutaneous approach. Our algorithm, we try to see if a patient can be treated by regular transfemoral approach. If not, we see if we can consider it for intravascular lithotripsy assisted transfemoral. If this is not possible, we will look for the transaxillary approach. And if this is not an option, we look if transcaval could be an option. So in this way, I go further to the percutaneous transaxillary approach, which I think I can immediately continue on. So I think I would like to show here some practical slides, how to exactly perform this transaxillary percutaneous axillary approach. And I think this is a very easy approach for, especially if you're a smaller volume center and you're used to absolute majority of your cases transfemorally. If you go transaxillary, it's basically, you don't need any additional tools or gear. You can almost use everything what you're used to do by a transfemoral approach. And also the feeling for the operator when performing this procedure is almost the same as transfemorally. So first of all, we start with placing a 6 French sheet in the radial artery. And through this 6 French sheet, we introduce a pigtail catheter, a regular pigtail catheter. We bring this pigtail catheter up to the medial edge of the humeral head. As this is exactly the place where we want to perform the puncture in the axillary artery. And what we typically do for having a good puncture is I like to use both a combination of X-ray and also ultrasound. Because only using ultrasound, you miss typically orientation of your needle. It's not very obvious from where to come. And also using only X-ray, you also miss out on some information. So I would advise using both. You don't do X-ray a lot. Just a few seconds sometimes is enough to guide as an additional lens. And I always try to do the puncture of the artery here with a puncture, my micropuncture set. So after you've done the puncture, you bring in the micropuncture dilator and you change to a 6 French sheet. On that moment, sorry, I can go back. So here, of course, we always look very good on our CT if this vessel is really good, eligible for transaxillary approach. And on the right-hand panel, you see this typical spot where we do the puncture with a micropuncture needle. As you see, it's very lateral on the chest, on the thorax, almost into the axillary pit. And we have actually our patients just draped with the 2 arms besides the body. So not the arms in a 90-degree angle with an extra tape. No, we just place the patients as regular on our operation table. Next, we remove, of course, the pigtail catheter before we place the, well, you can also use another closure device, but typically I like to use the ProGlide closure device system. Anyway, you can also use other, even collagen-based like Manta closure devices. But if you like to use the ProGlide here, then of course it's important you remove your pigtail catheter first, otherwise you risk to shoot the needles through the pigtail. That would not be great. Next, after placing the ProGlides, you can bring in an 8 French sheet, and on that moment we also insert the safety wire coming from the radial 6 French sheet. And we leave this safety wire. I typically like to use a 0.018 wire, for example, a platinum wire, and we place this wire all the way through the axillary subclavian artery and into the descending aorta. And we leave it there for the entire procedure. Through this 8 French sheet, you can try to come with your catheter, AL1, for example, catheter to cross the aortic valve, bring in your stiff wire, and then from there on, as soon as you've placed your stiff wire into the ventricle, you can come with your introducer sheet. And what I or also my colleagues typically do is that we do not introduce this introducer sheet further than necessary into the subclavian artery. So typically we only introduce it up to the horizontal part of this subclavian artery, and we do not let it go across the bends up to all the way into the aorta. This is not necessary, especially if your patient would even have a lima bypass patient. We would do everything to avoid to cross the lima artery. After that, we just do our regular TAVI as normal. We would do by transfemoral approach, and after that we can just take out the introducer sheet and close our artery with the ProGlide or another vascular closure system. The good thing is that we have here always a bailout possibility with the safety wire which is in place. And this gives us the possibility to bail out if we don't have a PERC closure with an 8mm balloon, or even smaller if the vessel would be a smaller size. And also, importantly, if we would have a complete failure of the vascular closure, this even gives us the possibility to introduce sheetless a covered stent. For example, a Covera stent, which we tend to use, although we have only needed in one single case so far, percutaneous transaxillary one-time bailout stenting, but it is definitely possible to insert a Covera covered stent 8mm by the radial access. So here you see some images. So you see the introducer sheet doesn't have to be introduced necessarily all the way. So this is it can be that this large bore introducer sheet sticks out for several centimeters during the entire procedure, but this is not a problem. And on the right side panel, you see a successful closure of the vessel. So we did also a small comparison of, well, this was a few months ago still, so where we compared our first 10 percutaneous transaxillary cases with the last 40 surgically assisted transsubclavian cases. And actually, you see that despite this, these were the first 10 percutaneous transaxillary cases in our center, you see that the complication rate was actually much lower using this percutaneous approach compared to the surgical approach. There were less major vascular complications. You see that there were 6 out of 40 in the surgically assisted cases which ended up with a major vascular complication. 2 of them had a major bleeding which needed actually covered stent placement and also blood transfusion even. 2 other cases were actually cases which ended up neural damage. So it seemed, and we haven't this at all with the percutaneous approach, so avoiding neural damage, and this was even permanent neural damage for the patient. So this is more seen in, at least in our cohort, in the surgically assisted than the percutaneously assisted transaxillary or transubclavian approach. Also, the hospitalization length can be much smaller in the percutaneous approach as you don't have a surgical wound, and also rehospitalization was actually not seen within the first month after percutaneous approach. So it seems to be a very safe approach. So as a summary, as I showed you before, we can do our entire program having now nearly 400 TAVR cases by a fully percutaneous approach.
All right, thank you so much, Dr. De Backer. That was an amazing tour de force. You're a real you're a savant with access, and we really appreciate that. I'd like to transition now to Dr. Yadav, who's fairly recently joined Piedmont, much to their delight, and I think he's a great addition there. And looking forward to hearing a little bit about Transcarotid TAVR.
All right, thank you, Jamie. So this is an example, case example, a 76-year-old male with symptomatic severe aortic stenosis with classic high gradient AS, calcific valve, mild AI with a mean gradient of 40, who was referred for transcatheter valve replacement. And this is the coronary angiogram. He had history of bypass grafts that showed patent lima to LAD and a vein graft with severe native coronary artery disease. The CT analysis had shown an annular area of 443 with a perimeter of 76, nice big sinuses, not much calcium in the LVOT, and coronary heights were all reasonable. At the time of his initial coronary angiogram, the operator took peripheral angiogram because of the history of peripheral arterial disease and bilateral iliac stenting, and you can see that he has bilateral common iliac stenting with possibly some narrowing on the right side, which when we look further on the CT scan, you can see this is just the right common iliac stent, and the upper part of the stent, or the proximal stent, is underexpanded with a diameter of less than 4 millimeters. And the bottom part of the stent seems to be expanded fairly nicely. The left side was a little better with an average diameter over 5 millimeters. Not much tortuosity, but still a short stent. So the team at that time decided to proceed with a transfemoral TAVR using an evolute valve. And this is the initial angiogram. You see some calcification in the common femoral. Then the external iliac looks okay. But the issue then came up that a 12 French Cook dilator would not advance the stent on the left side. And this was despite various wire changes, lubrication with Rotaglide. And the team at that time, the operator decided not to pursue it further, not to balloon expand because of possibility of friction with the stent, and felt that we should probably abort TAVR at this time and consider alternate access at a later stage. This is the final angiogram, and you can see that there is some dissection at the lower edge of the stent, just telling you the injury that was happening with the dilator advancement. So then the patient was referred to us, and this is our CT analysis that showed nice big right subclavian over 8 millimeters, and the left subclavian was also reasonable size. However, there was osteostenosis, not very tight, but still some narrowing. And remember, this patient also has lima. Carotid access was very good bilaterally, really good luminal size. Right size was over 7 millimeters, left carotid 7/8. Carotid duplex did not show any significant disease on either of the internal carotid. This is relatively important if you're going to put a sheath on one of the carotid. Want to make sure the contralateral carotid does not have stenosis. So the patient underwent general anesthesia, right transcarotid access, really straightforward valve deployment. The valve does come a little canted sometimes when you're coming from the carotid, but slow inflation will give you a chance to optimally position the valve. Deployment, final angiogram, good high placement, and the patient was discharged without any issues in the next 1 or 2 days. This is the final angiogram, excellent result, no PVL, mean gradient 6.4. So in conclusion, no one access is perfect and will work all the time. An ideal transcarotid may be better than not so ideal axillary, transcaval, or lithotripsy, and this comment is true vice versa also. Sometimes transcaval may be better than not so ideal axillary and vice versa. So if you're a very busy program, maybe you need to learn all of these, but if you're less busy, then maybe master one before move to the next. This is somewhat our algorithm that obviously femoral is the best and the preferred way. But then intravascular lithotripsy has the potential to convert an access almost like femoral. Few minutes of lithotripsy in short calcified segments could essentially make a non-transfemoral case femoral, and therefore making it very attractive option. And then obviously axillary carotid or transcaval, depending on patient's anatomic characteristics and also your team skill level and what's your experience set with apical and aortic as the ultimate last options. Thank you very much.
Pranav, that was amazing. Thank you so much for that. We're going to turn now to your crosstown neighbor, Dr. Devareddy, who's going to take us through Transcaval TAVR, whether you're doing it outside the gates of Emory or in your own facility. So, Dr. Devareddy.
Thank you for the opportunity to present techniques and some case examples of both transcaval and lithotripsy facilitated TAVR. First, we'll take a quick tour through the thought process and methodology of transcaval TAVR. In terms of past medical history, starting out with a case, this was a 69-year-old gentleman who presented to our program and had a prior bypass that was performed. The patient was put on the table, sternotomy was achieved, a graft was placed with limited LAD, but at that time, the aorta was noted to be porcelain. The surgical planned aortic valve replacement was aborted, and the patient was transferred and referred to our team for further evaluation given persistent dyspnea. Patient had a history of prior known ischemic cardiomyopathy and known peripheral arterial disease. Ejection fraction had dropped quite a bit, but the numbers, despite the low EF, were still consistent with severe aortic stenosis. CT angiography revealed aortic annulus and other anatomic measures consistent with suitability for TAVR. Our measurements were consistent with 23 Sapien 3 desired valve. In this case, coronary heights were adequate. Our challenge arose here in reviewing the CT angiogram with the lower extremities, most notably, as you can see here, in the lower external iliac on the right and the superior external iliac junction with the common iliac on the left, a marked narrowing in both iliac arteries to below 3 millimeters bilaterally, taking out any possibility of routine transfemoral, or in our opinion, a intravascular lithotripsy facilitated approach. We then performed transcaval planning, and on the right side, you can see here that the abdominal aorta was not terribly calcified. We did feel that there was a suitable location in the abdominal aorta in proximity to the inferior vena cava that was also far enough away from both the aorta-iliac bifurcation and the takeoff of the left renal artery. Typically, we're looking for at least 25-30 millimeters of clearance to both of these anatomic landmarks. So why even consider transcaval? Well, as Dr. McCabe went through, there are a number of alternative access approaches that can be pursued now that have evolved beyond transaortic and transapical that are approaching these in more of a percutaneous approach. Within our Emory group, we do feel that Transcaval allows us to maintain femoral workflow and some of the muscle memory that we have as operators in performing these procedures and trying to maximize the benefits that we have seen with transfemoral approach. Similar to a percutaneous transaxillary approach, this is completely percutaneous, can be done within the same operating space that are done for routine transfemoral cases. In terms of radiation exposure, some of the scatter radiation may be less, given that the operators are in their normal positions, as you would be for a routine transfemoral case. And learning this technique affords some parallel work for other types of procedures, such as placement of left ventricular support devices and other large bore devices. The technique, although may seem intimidating at first, is typically reproducible and similar from case to case. The majority of it comes down to case planning in deriving these ideal angles and location of the inferior vena cava in proximity to the abdominal aorta. We identify these positions both in relation to the lumbar spine behind it, and then derive the appropriate gantry angles so that we can identify the location for ideal electrosurgical puncture from the inferior vena cava to the abdominal aorta, both in an antero-posterior position and a lateral camera view, although we can do a lot of this now in the AP view by itself. Once we get catheters in position, typically with a 55-centimeter renal guide in the inferior vena cava and a standard guide in the aorta, waiting with typically a gooseneck snare, we can activate and electrify a coronary wire, typically an Estado wire, to go from the inferior vena cava, pass through the snare, capture and snare that wire in the abdominal aorta, and then transition this to a sheath. And then at the end of the procedure, close the fistula with an occluder device. And we'll go through this in more detail here in just a second. So here's an example of that evaluation for this patient. Just between the third and fourth lumbar bodies, we did feel that there was an appropriate target to aim for from the inferior vena cava. We can see a simulation of what we would see on X-ray, both from an AP view and as well as a lateral view here, where we can line up the inferior vena cava and the abdominal aorta. If we need to, we can put pigtail catheters in both so we can get those exactly lined up. And we use, again, as we mentioned, the lumbar bodies as a landmark reference for exactly where we want our catheters positioned. You can see here, superiorly, the inferior vena cava is in proximity. And what we're trying to do is achieve a crossing right at this point. The abdominal aorta here has a soft wall next to this. Electrify this and pass the wire through for snaring. So in this specific case, as we mentioned, we would try to do this just below the third lumbar body. We would have, based on the size of the abdominal aorta, we picked a 15-millimeter gooseneck snare to capture the Estado wire as it passes through. The wire is typically attached to a grounding pad and electrified. There's certain techniques that I won't go into in terms of being able to reproducibly and safely electrify the wire. But typically it requires denuding the wire at the back end of it. Once the wire is in the abdominal aorta, a series of mother-daughter catheters, in this case, a fine cross and a natty cross can be used to upgrade from the 014 wire to an 035 Lunderquist wire. And at that point, it becomes what you are used to as a transfemoral TAVR. In this case, 14-French sheath was advanced. We plan to do a TAVR with a 23 valve, and on the way out, close the fistula with a 10-8 amplatzer ductal occluder device. In this case, we did do this procedure under general anesthesia, although we have done some of these cases now with conscious sedation in carefully selected patients. So first, for the Transcaval Crossing, this was an abdominal aortogram performed, just confirming the anatomy that we had seen on the CT scan. In this case, we have the 55-centimeter guide positioned in the inferior vena cava, a 6-French GR4 guider in the abdominal aorta with the gooseneck snare positioned, waiting for passage of the wire. The wire is electrified, and here you can see as it crosses through directly into the body of the snare in that position. At this point, the catheters are passed through the aortocaval fistula first, a small piggyback catheter, then typically a fine cross or navy cross, and then we can transfer and upgrade the wire to an 035 Lunderquist, slowly pushing the sheath through. In a very calcified aorta, care must be taken to not push too aggressively. Typically, this will pop. These sheaths are extremely hydrophilic and have good transitions, but typically making this transition is not a problem. At this point, this becomes a routine TAVR that you're used to, routine deployment here with valve in good position. So the other challenge is that we've now created this aortocaval fistula and need to ensure that we have a dedicated and durable closure of this on the way out. So first what we do is we exchange the TAVR delivery equipment and actually place an Agilis catheter, typically a medium bend Agilis, through the large bore sheath. And inside of this we have, you can just see the nose of it peeking out the top of the Agilis. We have a 10/8 Amplatzer ductal occluder that's been prepped and is waiting to go. The large sheath actually needs to be brought back fairly quickly. You don't want to dilly-dally and have the large bore sheath sitting in the space between the inferior vena cava and the abdominal aorta. You may ask why that is. So if you were just to pull everything out and leave the aortocaval fistula, to your surprise, it's actually typically not a life-threatening situation. There is a pressure sink such that the intra-abdominal space is at a higher pressure than what is seen in the inferior vena cava. So typically blood will flow from the abdominal aorta through the peritoneal space into the inferior vena cava, unless you have a catheter that's obstructing that flow. So if you pull this sheath back and obstruct the orifice of the inferior vena cava portion of the fistula, then you may bleed from the abdominal aorta into the peritoneal space. But as long as the sheath is brought back very quickly and the space is open in the inferior vena cava, blood will just safely pass from the aorta to the inferior vena cava while we're trying to position the closure device. So here the Agilis has been brought back. It has been steered such that it's pointing more inferiorly. And at this point, the hat of the ductal occluder can be brought out. And this is brought back so that it is in proximity to the medial abdominal aortic wall. You don't have to pull this too tight. You just want to make sure that you have apposition. And once this is, once it's felt to be secure and positioned against that wall of the aorta, the cable can then be pulled back and then pushed forward so that the device is in a comfortable and natural position. The Agilis catheter is brought back. We would always give protamine to reverse anticoagulation just before this step is performed. And then we can do a confirmatory angiogram after 10 minutes of protamine. In this case, you'll see that there's actually no leak whatsoever. This will be what we would describe as a type 0 leak, in which we see no extravasation from the abdominal aorta to the inferior vena cava. So overall, transcaval techniques can be pursued in a way that is safe and predictable. It's the technique in these small steps of knowing how to maintain safety such that there is no bleeding that transpires into the peritoneal space. But if the technique is learned carefully, typically with proctorship in the beginning, this is a technique that can really turn alternative access into more of a routine transfemoral approach. Trying to maintain the overall workflow and logistics of transfemoral TAVR, however, has been greatly facilitated with the technology of intravascular lithotripsy. In a case where I'll try to highlight the use of this technology is in this 78-year-old gentleman It was transferred to us for a history of unstable angina. Troponin was mildly elevated. And in talking to this gentleman, pain had actually been progressive over 2 or 3 months. There's a known history of coronary bypass surgery in the past, and also a known history of aortic stenosis, which was being followed medically. The patient also had known peripheral disease with a prior stent to the left subclavian. Urgent angiography was performed, which actually demonstrated patent grafts and no significant de novo native coronary disease. But on echocardiogram, at first the patient was felt to have low gradients and preserved LV function, but on a further deep dive of the echocardiogram, it was found that the patient had a low aortic valve area with a low stroke volume index consistent with severe paradoxical low flow, low gradient physiology consistent with functionally significant critical aortic stenosis. We were consulted for TAVR evaluation. CT angiography was performed, demonstrating anatomic suitability again for TAVR, in this case with a 26 SAPIEN 3 valve. Coronary heights were adequate and safe for deployment of the valve. CT angiography of the lower extremities demonstrated a significant challenge right at the bifurcation from the aorta into both iliac arteries. As you can see here, near circumferential calcium right at the bifurcation, very eccentric, bulky calcium in the right common iliac artery. It's not seen here. There's actually some additional calcium lower down in the external iliac transition from the common iliac artery. So in this case, we, between both, felt that we may have a better chance of advancing the valve on the right side, but in performing lithotripsy at the bifurcation, there was some concern in potentially jailing the contralateral iliac artery because of the nature of calcium deposition and lesion deposition right at the bifurcation. So our procedural plan in this case was to try to maintain the benefits of transfemoral TAVR, but to facilitate this with intravascular lithotripsy, but to actually perform this with kissing balloon inflation and bilateral lithotripsy at the bifurcation to change the compliance of both lesions and to reduce the chance of obstruction of the contralateral iliac artery. In these cases, we typically do these with conscious sedation to really maximize the benefit of the transfemoral workflow so that we can mobilize these patients and realize those benefits of ideally potential next day discharge. Here's the baseline aortic angiography, which confirms what we had seen on CT scan. In this case, we started out first at the bifurcation. I think there's differences in techniques given the novelty of this procedure and what we think might be the best approach. In our center at Emory, we feel that lithotripsy is more of a calcium modification technique, and we really do our best to try to avoid injury that may be derived from barotrauma. So in almost all cases, we'll use a 7x60 balloon, as Dr. Devakar had mentioned. We'll typically not go to more than 3 or 4 atmospheres unless we're dealing with a very resistant lesion where we may go as high as 6 or 8 atmospheres. But that's actually typically rare now. We'll try to keep this at very low pressure. And what's amazing is that despite this balloon being inflated to 3 atmospheres, you actually see a small waist, once you get to 1, 2, or 3 atmospheres. Just at that low pressure, once you start delivering energy, which is at 30 seconds treatments each, before the machine will time you out, after 1 or 2 treatments, you'll often see that the waist resolves just with application of lithotripsy with no further higher inflation pressures. Given that the balloons will typically allow us to perform 300 seconds or pulses of treatment, I'll typically try to give patients their money's worth and maximize the treatment in the balloon, but again, staying at very low pressure. So here we're just changing the location of the emitters in relation to the calcific deposition here. And these are just different 30-second treatments. And again, we're just staying at 3 to 4 atmospheres of pressure. Came down a little bit further to make sure we are treated the calcium a little lower in the common iliac. And as I mentioned, there was a focal spot of calcium in the common to external iliac transition, just to make sure that the sheath didn't encounter any friction or resistance at this point. We just did a 3-atmosphere inflation here with a 30-second administration of lithotripsy pulse. Came back to the bifurcation. As you can see, that waist that we saw at the beginning, despite low pressure, has now been modified and is not as obvious here as we go into our further treatments. So I typically, in our practice, will be patient. We'll do repetitive applications of lithotripsy, trying to avoid going over anything of 6 atmospheres. And generally in our practice, unless we run into problems in trying to advance the sheath, and this is the angiography, but after we have performed lithotripsy, we don't see any evidence of trauma to the vessel node dissections. Occasionally you may see a low-grade dissection as you would see in balloon treatment alone. We'll typically leave those alone unless there's any evidence that it's propagating or flow limiting, but that's typically rare at low pressure, and as it was in this case. So to advance the sheath, we then turn this into a routine transfemoral case. You'll see the sheath advance here. It does encounter a slight pause right there and then passes through. You may see that commonly with slow, steady pressure. It will advance. If we don't see the sheath advance, we have continued friction, then we might change out to a short sheath and then go back with a non-compliant balloon and perform an additional inflation. But in our center, we have actually not been doing routine additional inflations of non-compliant peripheral balloons just to try to avoid barotrauma from higher pressure inflation. At this point, as I mentioned, it becomes more of a routine TAVR with best practices for valve deployment. See our valve's in good position, and our final aortogram reveals well-positioned valve with maybe a trace paravalvular leak. So at the end, as long as our creatinine will allow, we do like to take a final aortoiliac angiogram just to demonstrate no evidence of injury. I think we'll have to learn more as we go further along in our experience of whether we'll try to leave these iliacs in a way that we're treating them just enough to pass large bore sheaths, or especially as we get into lower risk patients, are we going to want to treat them in a way that we maximize the patency and luminal gain for flow into the aortoiliac vessels. For now, we've been taking more of a minimalist approach and treating them in just a way to maximize passage of the sheath. So we may see some residual stenosis at the iliac arteries, but as long as we've been able to achieve a successful TAVR, the patient doesn't have any history of significant lifestyle limiting claudication, then we are not going back and stenting these or performing any additional balloon therapies. Except in the rare instance where we may see a vascular injury, in some of the data that we've collected so far that Dr. McCabe showed earlier, we did see frequent low-grade minimal dissections, and you might see a slight edge tear, but we hardly ever saw anything that required anything more. There were no ruptures, no perforations, and no flow-limiting dissections in our early experience. So in conclusion, currently in 2020, when we think about alternative access for TAVR as presented for these 2 cases for transcaval and transfemoral facilitated with lithotripsy, our center at Emory feel that these 2 techniques can allow operators to utilize the familiarity of a transfemoral workflow and try to afford early mobilization, potential next day discharge, and the benefits that have been seen in avoiding the risk of non-transfemoral access, especially this may be especially relevant for centers that may not have the volume or experience to really gain the familiarity with more complex procedures such as transcarotid transaxillary or transcaval. So in conclusion, we're trying to preserve best practices for transfemoral and try to piggyback onto those outcomes that Dr. McCabe has shown again. Thank you for your attention.
Those are three terrific presentations. So thankful to have some of the world's experts on vascular access and complex structural intervention here with us today. Thank you again to all of you, and take care.
Thank you.
Thank you very much.
Thank you.